Welcome to EconTalk, part of the Library of Economics and Liberty. I'm your host, Russ Roberts of Stanford University's Hoover Institution. Our website is econtalk.org, where you can subscribe, comment on this podcast, and find links and other information related to today's conversation. You'll also find our archives where you can listen to every episode we've ever done going back to 2006. Our email address is mail@econtalk.org. We'd love to hear from you. Today is September 11th, 2015, and this episode is a follow-up of sorts to the interview I did this summer with Alvin Roth. In that interview, we talked about some of the creative ways that Roth and others have helped encourage kidney donation. And at one point in that episode, Roth mentioned in passing that there's only one country in the world where it's legal to buy and sell kidneys, that country being Iran. And I almost asked Roth about that and what he knew about it, but I missed the chance. The interview moved along. And that was that. And then, as fate would have it, a few weeks later, Tina Rosenberg, author and writer at the New York Times, wrote a piece in the Times on the Iranian kidney market and the possible implications in a second piece that she wrote for the United States. And she is our guest today. Tina, welcome to EconTalk.
It's a pleasure to be here. Thanks.
So to start with, here in the United States, there are a lot more people who want a kidney transplant than there are kidneys available, and this is true in most countries in the world. What happens to those folks generally who are desperately in need of a kidney because their kidneys aren't working?
Well, some of them have relatives or friends who can donate a kidney, and therefore they can have that transplant done. Kidney matching is fairly easy to do. There's a lot of leeway. It's not anywhere near as difficult as trying to find, for example, a match for a bone marrow transplant. So in a lot of cases, that does happen. The people who don't have that, however, have to go on a waiting list. And in the U.S., that waiting list varies a lot by region, but in some places, it can be as long as 10 years. And in the meantime, they're on dialysis, and a lot of people don't survive that long.
And dialysis, I think it's about $80,000 a year. Is that correct?
I think that is right. Yes. Mm-hmm.
And it's a strikingly...
Which is paid for, by the way. This is the one kind of treatment that Medicare pays for no matter how old the patient is.
Yeah, it was a strange thing. If I got this number correct, I think 28% of Medicare's budget is dealing with kidney problems, which is rather surprisingly large, at least to me.
Wow. That is, I did not know that. That's amazing.
I hope it's a true statement, but I think it is. I've got a few other facts here just to set the stage. It says there are currently 123,000 or so people waiting for transplants in the U.S. Of any kind. 101,000 are waiting for kidneys. That's as of April of this year. So think of 100,000 people. In 2014, there were 17,000 transplants. That's a huge number. It's wonderful, but not when there are 100,000 people waiting. And of those 17,000, 5,000 or so came from living donors, and about twice that many came from people who had died in a car accident or other ways that allowed them to donate their kidney. And
Right, we forgot about that. That's very important. Deceased donors are very important, and obviously they can give 2 kidneys instead of 1, so
Correct.
They can save 2 lives.
And a few last facts. Over 3,000 new patients are added to the kidney waiting list each month. Tragically, 12 people die each day, 12, waiting for a kidney transplant. And in 2014, that was 4,270 people who passed away, and another 3,617 became too sick while waiting to be able to receive a transplant. So this is it's a terrible, terrible problem, and my understanding is it's getting worse as diabetes is growing.
Yeah, obesity is a big problem that is causing diabetes, and diabetes causes kidney failure. So with rising obesity and diabetes rates, people needing kidney transplants, that number has been rising and rising.
So what happens in Iran that's different? The only country that allows there's a lot of black market activity in kidneys around the world, but in Iran it's legal. So what happens there?
Well, when I first heard that Iran pays kidney donors, I thought, that's a big black market right there. But that is actually not the case. It is not the black market. In some ways, it's a response to the black market, because if you can buy a kidney legally, then you don't have to do one under the table, which leads to all sorts of abuses. Iran, out of necessity after the revolution, well, let me just back up. After the revolution in 1979, Iran was broke. Their assets were frozen overseas. And so they decided they couldn't support people on dialysis, because dialysis is actually much more expensive than providing a kidney transplant, because a kidney transplant you do once and dialysis you do forever. So they started sending Iranians who needed kidney transplants overseas, mainly to Britain, to get them, all expenses paid. And that then became unsustainable for them. So they said, we are going to start a program where we pay kidney donors. And the state set up a price. There was a system that was run by kidney patients, essentially. There was a lot of testing done, medical testing and psychological testing and financial counseling for people who were coming forward to try and sell their kidneys. And very important, the rule that you had to be the same nationality as your donor, which meant that people could not come from overseas and get kidneys from Iranians. Only Iranians could get kidneys from Iranians, and Afghan refugees had to have donors who were also Afghan refugees. So they started this system where they eliminated essentially their kidney waiting list. People could get matched instantly. In fact, it was the donors who were on a waiting list. I want to donate my kidney. I've gone through some testing, and now I'm just waiting for the right patient to come up. And that worked quite well for a while. It works considerably less well today, largely because of budget issues. But the donor system is still in place in Iran, and still has essentially removed from the equation the long wait to find a kidney donor.
So let's talk a little bit about the monetary part of this. There are costs to doing the operation, the transplanting, the removal of the kidney, and then transplanting the kidney into the recipient, obviously. There's costs associated with testing, counseling, pre-op, post-op, et cetera. And in addition, there's the payment for the kidney itself. So try to describe how that fits together.
Right. Well, the medical costs are paid by the government. That is something that is not a burden for the patient. However, in the beginning, it was also the government that paid the kidney donor. There was a regulated system where the government paid a donor the equivalent of about $3,500, which was
a lot of money.
And a lot more than it does now, yeah.
Sure.
And it wasn't called a payment. It was called a gift for your altruism. And also the donor could negotiate with the patient for more money. The patient could also provide an extra gift for altruism. And that negotiation was conducted in private, so nobody knew what happened. If a donor was being extortionate, then the patient could complain and would instantly be assigned another donor. So donors didn't have a huge amount of leverage in that situation. So that was really the cost to the patient. Over time, however, the government payment has eroded, and now essentially it is the patient who is paying the donor. And that has created lots of problems because poor patients can't do it. There's a lot of charity to help poor patients pay donors, but in some regions of the country that are particularly poor, like in the Kermanshah region, that charity runs out about halfway through the year. And so essentially their kidney donor system has broken down as of July, or as halfway through the fiscal year in Iran. But that's how it's supposed to work now. Mainly the payment now comes from the patient.
And there's presumably some culturally or market-based combination of both price that's, I assume, somewhat well established there. I assume it's not, the prices aren't all over the map except by region.
They're not.
They're all over the map because it's not a national market; it's a regional market.
That's right.
But go ahead.
No, the government has set a price. Actually, it's just about it's over $5,000, and the government pays $350 of that. So all the rest is on the patient.
And as you say, there's some charities that help with that. They may not do so well in some settings, some parts of the country, some types of patients who are so poor they struggle to pay that. But overall, it works pretty well. There's some other problems with the system, though, that people complain about.
I'm not sure I would say overall it works pretty well. The money is a big problem.
Why?
I mean, the interesting thing about the Iran system to me is that this is a fairly poor country that's doing it. And the problems that it has run into are poor country problems. They're not problems that are inherent in the idea of paying kidney donors. Rich countries could adopt this system and do a much better job with it and not have these issues, like, for example, running out of money halfway through the year.
But what are
That's why I was interested in writing about Iran. But for them, the huge budget cuts in this system have been a very big issue that really means it's, basically if you can pay for a kidney, you can get one. And if you can't, in a lot of places, you have to wait a long time.
But there are other issues that people worry about. One of the things you wrote about was the post-op experience. There's not a lot of follow-up. Some of the patients deliberately either find it costly or they don't want to be dealing with the system after they've made the donation and gotten the money. So talk about what some of those issues are.
That's right. Yeah, they've found it very difficult to make sure that after the operation, the kidney donors get adequate medical follow-up. And they're supposed to get a year of health insurance, although actually now I think everyone in Iran gets free health insurance. But a lot of people didn't come in again, and they found that the donors had given the transplant organizations fake telephone numbers. Now, why would they want to do that? One reason is that because donors are paid, it's a bit stigmatized. People assume, if you're donating your kidney, you're a drug addict and you want money for drugs. In fact, that's almost never the case because those people are screened out. And there's even financial counseling, so organizations won't allow kidney donors to donate a kidney unless they feel that the money they'll get is actually going to solve their financial problems. If it's only going to make a small dent in it, these people sometimes get turned down. So it is stigmatized. But I just read a very interesting study that said even with related donors, people's friends or family, those donors are often lost to follow up after the surgery.
They don't trust.
I'm not sure what that means.
Well, a lot of people
don't feel like they need it.
Yeah,
it's a perfectly safe operation. We don't need a kidney. Your chances of survival with one kidney are essentially the same as with two, because if you're going to get an infection, you're going to get it in both kidneys anyway. So there's not always a lot of need for medical care afterwards.
Well, I understand the idea that you don't want to go into a doctor's office if you feel okay, because they might want to take something else out. There's a certain
which they won't pay you for.
Right. There's a certain unease about. I'm sure there's a natural human thing about coming back into the facility. I would think unless you have some serious problems, you probably just say, "I think that's done," there might be some psychological related issues I want to come back to, but
yeah. Some people don't really want to meet with their donor and recipient meetings, which used to be in person, are now places not in person because it's just uncomfortable. It's psychologically uncomfortable. Some people want to meet their patient or their donor, but a lot of people don't.
And the same, I assume, is true about the recipient. They want to meet the recipient or they don't.
Exactly.
Yeah, I was thinking about Maimonides, the 13th century Jewish scholar. When he ranks charities, he has a ranking of charity, and the highest level of charity is to help someone get off charity, to give them a job or teach them a skill. But once you're giving somebody money, and we've been talking about charity a little bit lately on EconTalk, so I thought it's a nice connection. You're giving people money or resources. He emphasizes the importance of anonymity, and he mentions that it's a high level for the donor not to know the recipient and the recipient not to know the donor. And in a way, you think, well, that's kind of wouldn't it be great if they knew each other? And But in fact, in these situations, many times there's a deep unease because the debt is either too large to be repaid, or the person who's made that gift feels that maybe they're owed something that can't be paid. I don't know. I can imagine there are issues there.
Yeah, it is. It's very complicated.
So talk about the charity that's involved in this. You called it a middleman in your piece. This is a non-governmental agency, as I understood it. It's a private organization that helps make this market work. Tell us about it.
Yeah, it's really important to not have a middleman who makes a profit, because otherwise they would have incentives to make matches and create transplants where they would be medically inappropriate. So you don't want someone who has a financial incentive in making transplants happen. So there are associations in every region of Iran that are there are dialysis and kidney transplant patient associations. So it's often the patients themselves and their families, and they run these non-governmental organizations that are the places that donors come into to say, "Hi, I want to give my kidney," and then they handle all the paperwork. They send them to a place to get their medical tests, et cetera. And they also are places that maintain funds to help people who can't pay kidney donors to get the money to do that. So that's a very important part of the process. You don't want brokers in the middle who are going to take a cut or who have a financial incentive.
I'm not so sure about that. We don't have any experience with such brokers, but often in markets.
Well, that's how the black market works, right?
But, but the black market's
that's classic. You have the rich person coming from the West, North America or Europe or Israel, and they go to some poor country and they contacted a broker and they pay $150,000, and the broker gets $145,000 of it, and the poor donor gets $5,000. That's not what you want.
Well, it depends. It depends on the quality, and when you're doing a illegal transaction, it's much harder for brand name and reputation to help improve those situations, right? So I started to say we don't have a lot of experience with how a for-profit broker would work in a legal market, right? So, for example, you might argue that if it's a for-profit market, groceries wouldn't have an incentive to provide healthy food because they could save money on oversight, but then they lose their reputation and they go out of business. So if there's an open market, on the other hand, with a black market with, say, drugs in the United States, say where drugs are talking about recreational drugs now, it's hard to have quality because my brand name might be difficult to establish because it's an illegal under-the-table activity already. So I just want to put that out there. I don't disagree with you that a nonprofit can do a wonderful job, but sometimes for-profit is better, and I don't think we have a very good understanding of that. Certainly, in the situation you're talking about, a for-profit can be exploitive, and especially in illegal markets, and that's so I agree with you on that. Is there more than one of these nonprofit charities that does the coordination, or is there a national one, or is there one in each region? Do you know?
There's one in each region, and each region's policies are a bit different. For example, in the Shiraz region, they don't use a paid donor system. Shiraz was the first region to develop a deceased donor program, and they've been doing a really good job with that. In part, they've been able to do that because of the infrastructure that was set up by the paid donor system. You need doctors who know how to do these transplants. You need hospitals that can do them. You need testing facilities. And now Shiraz has moved into this deceased donor model, and it works well in part because if you need a kidney in Shiraz and you wait for a deceased donor, if you don't get one in 6 months, then you can go elsewhere and get a paid donor. So you
outside the region.
You have that, exactly. You have that safety valve. And people don't have to wait that long for deceased donors because there is the paid donor system.
Sure.
So they complement each other. There's some controversy. Some people say, well, the establishment of the paid donor system has precluded Iran from doing the deceased donors. But there's a lot of people in Iran who disagree with that, and they feel like, no, it's been helpful. But the good news is that deceased donor is increasing in Iran, and that's very important.
I was just I think what a medical fact, which I was surprised to read, is that your life and there could be selectivity bias, selection bias here in the data, but this evidently is the raw data, that your life expectancy, I was going to say your probability of surviving, but your life expectancy when you're on dialysis versus receiving a kidney from a deceased donor versus receiving a kidney from a live donor are very, very different. So dialysis tragically is you can't stay on it forever or very long even. It doesn't, a few years I think is the life expectancy. But a live donor kidney works better in your body than a deceased donor kidney. So something, again, assuming there's no selection bias in the kidney, there's something destructive that happens, not surprisingly perhaps, in that weight, in keeping that kidney functioning in some dimension once the person's passed away versus a live kidney transplant. So live kidney transplants are, quote, higher quality.
Yeah, that's right. Deceased donor transplants, very often the kidney doesn't start working right away, and you have to be on dialysis for a day or two before the kidney sort of gets jump-started. It is slightly different, although, as you say, both of them are far superior to dialysis.
It's a live kidney
doesn't clean your blood very well. Most dialysis cleans about 15% as well as your kidneys do, and the toxins kill you. A donation of a live kidney the average is, I think, is up to 20 years. Not the average, but it's up to 20 years survival, which is, I don't know whether you die from kidney problems with that, what it means to say your life expectancy is 20 years, but that's pretty good. And you can then get another one afterwards.
Yeah, I wonder if there's if they're working on a 3D printed kidney.
Well, that would solve a lot of problems.
I can't help but think of it. And the other thought that I'm embarrassed comes to mind is that this is the ultimate example of the sharing economy. You have your car sitting in the driveway, or your house when you're on vacation. Better example. You're not there, so why not rent it out? Your car at the parking lot. You can rent out somebody else's car in a parking lot at the airport now while they're on their trip. Well, that second kidney is just sitting there. So this is really the Uberification of medicine, at least in Iran.
I hadn't thought of it that way.
Yeah, I hadn't either. It just came to me while I was reading your work.
Yeah.
If you listen more to EconTalk, Tina, you'd think of it that way because we talk a lot about the sharing economy. Something to look forward to. Let's see. Do I want to ask you, is there anything else? Oh, the other thing I want to ask you about Iran before we move on to some issues of reform. You described it as, quote, a safe operation. It's relatively safe. It's still the old form of, I guess it's a joke, minor surgery, something that happens to someone else. Right. A safe operation is one that's done on someone else too, I guess. Do you know anything about how dangerous it is to be a donor in Iran versus other countries of similar, say, income level, or versus the United States, where we do live transplants too, just not through an open market? Not
paid. My guess would be that there is a higher death rate in Iran of donors, although probably still extremely low. But it's not because the medical care is worse. It's because when you pay donors, the people who are going to be donating their kidney are very poor people. And Correct. Very poor people tend to come in sicker than middle-class people. Yep. So you're dealing with a patient base that's going to have more underlying problems. Although obviously they're screened, and if people come in with obvious underlying medical issues, they're not accepted as donors. So I think there is the possibility of complication or death, and it's probably slightly higher than in systems that don't have paid donors, but it isn't very high. It is still a very safe operation. I do want to say something that's important, though, which is it's not the case in Iran that because you have a paid donor, you get your kidney 2 weeks after you need one, although I've talked to somebody whose friend got a kidney 2 weeks after he decided he needed one. You wait for many reasons. They're just not reasons of finding a donor. For example, even once you've been matched with a donor, you have to go through medical tests. Your donor will go through more specific medical tests. You have price negotiations. If that donor is found not to be a match or pulls out for another reason, then you start that process again. There's also many reasons there are other reasons that people wait. So there is a waiting list in Iran, and there's a lot of people on dialysis who just choose not to get a kidney transplant, which is the head of the Iran Renal and Tissue Bank said that there is a lot of people who don't want kidney transplants in Iran. It's not as I guess it's not as seen as acceptable as much as it is in the United States, where here it's just a clear preference.
Well, it's a little bit of a weird thing.
So there are people in Iran who are on dialysis. There's lots of them. And there are people in Iran who are waiting for a kidney. But the key is that in most places, except for these exceptions in Shiraz, where they do the deceased donors, and in Kermanshah, where they run out of money, and in other places where budget problems have caused a breakdown in the system, they're not waiting for a donor, and the wait for a donor is the significant wait in, I'd say, every other country of the world that does transplants.
And thinking about the cultural issues, joking about the sharing economy, but when you rent a house on Airbnb and you walk into a stranger's house, it's a little weird to be in their house with their stuff. It's not a hotel. And it must be weird for the people renting the house to have strangers in their house. Well, for some people, I suppose, taking somebody else's kidney is just weird. It's like there's something slightly macabre or creepy or eerie about it. I don't know, but I have actually a donor ligament in my body, which is of course nothing like having a kidney, but it is a piece of someone else's body that's in mine, and never produced a second thought in my case. But I can imagine for some people it would be. And we should also mention dialysis is not pleasant, so it's not like you just go in and you take a pill. It's so people who are turning down this either out of fear of surgery or for cultural reasons or emotional, psychological reasons, it's not an easy thing to be on dialysis. So it's an interesting phenomenon. Definitely not. So you wrote a couple of articles, and of course we'll put links up to those at the Times. And they're very well written. They're extremely interesting, which is why we're talking. But
Thank you.
You're welcome. But I suppose there were other things that came to mind that didn't fit into those articles. And I just want to ask you, you talked to a lot of doctors in Iran. You talked to Iranians who were here in the United States. You read some books. And you reported a lot of facts, and we absorbed them as the reader. And I'm wondering if you got some other less tangible impressions. Are they proud of their system? Are they uneasy about it? Are there any things you could tell us about just the impression you got in talking to people who are inside this market?
It varies. In general, I think they're proud of their system. They feel that without it, they would have been in very deep trouble for a long time and still would be. But they recognize everyone who's involved with the system in Iran recognizes it has deep, deep problems, mostly financially related. But they do feel that this is a model that other countries can learn from. The other issue with Iran, and I'm sure we'll get into this now talking about the applicability for other countries, is that they're under a lot of criticism. There's a lot of ideological objection to the idea of paying someone to donate a body part to you, issues of exploitation. In my opinion, if you break those down and you really think through them, they don't hold up. That's my opinion.
Yep, we're going to get to that. And I agree with you.
And so the Iranians really do have to fend off a lot of pressure from outside to abandon the system.
Say that again?
Pressure from outside to abandon this system.
Meaning?
Meaning that, for example, a lot of global transplantation societies constantly condemn this and say, we should not be paying kidney donors.
And that's it. So, and Iran is trying to hold on to that, keep their system the way it is, you think?
I think they're probably pretty accustomed to dealing with global pressure in many ways by now. But yes, they are trying to hold on to that.
Yeah, I'm not a big fan of Iran, but I'm happy to import something useful. This would be one of the things I would be happy to take. So it's I think it's wonderful that we have essentially a laboratory. We have some data, some experience. Of course, as you say, if we did it in the United States, we would do it differently for 100 reasons, and the outcomes would be different for 100 reasons. But the idea that it would obviously be an evil thing that would exploit the poor isn't generally happening. There are issues with that, obviously, but as you point out, doesn't have to be that way.
That's right. I think that's the important point.
But going back to this issue of just sort of the impressions you got, so they're under some pressure. Did they seem satisfied with it? Did they feel? Do they have guilt about it because of this? Not because it's. No, I'm serious. Not because. Is there some embarrassment in that they pay people for their kidneys? Forget the pressure part. I'm just. For example, let's take the opposite example. People in Canada, many people are very proud that they have free health care and that the system works the way it does. It's a source of national pride for some Canadians. Some don't like it, obviously. But a lot of people, it's a psychological benefit to them that they have this system. Did you feel anything like that in Iran or the opposite?
I don't know. I mean, I'm not really in a position to delve deeply into the Iranian psyche. But I did not sense any embarrassment whatsoever. I felt that people, the doctors and the economists that I talked to all felt this was a really creative solution that the world can learn from. And yes, it's got a lot of problems, but there's nothing to be ashamed of.
Yeah, just one other thing I want to emphasize. Obviously, this is the Iranian system is a mixture of what I would call private and public. The public is going through their national health system. The private, and by private, I don't mean for profit necessarily. People often assume private means for profit, run like a business. But I think it's important to remember that there's a third leg of that system, which is it's voluntary. In that sense, it's private. It's nonprofit, and it's in this case working with the public to have it happen. But obviously, when you say you don't want the government to do X, Y, or Z, it doesn't necessarily mean you want it to be all run for profit through business. And the middleman role that the charities play in Iran is an example of how civil society can help solve these problems in possibly ways that are much better than either for profit or purely public.
Okay, I agree with that.
Okay, that's just my little soapbox, because I find it frustrating. For example, but when I say things like I want to privatize this American school system, they say, well, that'd be awful. For businesses may be good at producing wheat or shirts or electronic devices, but they're terrible at schooling because they'll just enroll the best students and charge them the most money, and that could be true in a for-profit system. But we have lots of private schools that some do that anyway, and some don't do it. They're devoted to trying to help people who are very poor and want to finance their activities through donations or other means. So I just think it's really crucial when we think about social issues that we keep that third option out there, and that's a voluntary private option that's not the government doing it. Let's move to the United States. So you talk to these folks in Iran and talk to a lot of doctors and some patients, it sounds like. And as you said a few minutes ago, it seems like nothing really immoral about it. Did you have that feeling coming into this? How did, if anything, did your feelings change through these conversations?
Oh, they changed a lot. I came in, I had two assumptions that I think I no longer hold. And one of them is that paying donors is necessarily exploitative. And the second one is there are serious moral and ethical reasons not to pay donors. I no longer believe either of those things. So
try to put yourself back in your old shoes, or in the shoes of many people who still feel that way. What's the argument on their side? What's the exploitative argument and what's the immoral argument?
Well, the exploitative argument is look at what's going on around the world. You have what I described earlier, which is wealthy tourists who go to poor countries where they meet brokers who mistreat and exploit very poor, desperate people and don't give them adequate medical care. And they may, have their operation in some tent in somebody's backyard or the middle of the jungle or something. And that puts very poor people at their health at risk. And then they are forced to, they're not forced, but they are fooled into selling a kidney for far, far less than the patient is actually paying. Now, what I learned was you do have that system in many, many poor countries, but you don't have it in Iran precisely because they have this regulated, paid, official system. That they are paying donors without those issues. So that's one thing I learned.
Keep going.
Then there's the moral and ethical questions.
Well, let's put that. Let me just comment on the first thing first, and then we'll get to the moral issues and one of my favorite words, the commodification of things, which concerns some people and others less so. But I understand the issue. But going back to the exploitation part, it's interesting. I don't like the operation in the tent any more than you do, but the broker who collects $150,000 and gives $5,000 to the poor person, that person's getting about that same amount in Iran right now. It's just that the person who's getting the kidney isn't a rich tourist who's being exploited by the broker. So in a way, ironically, it isn't clear who's being exploited.
I chose that number.
You're right. It's probably more like 50.
Arbitrarily.
Yeah, good point. Fair enough.
Who knows what it is?
Yeah, you're right. Yeah. You're right. But there is an issue, which I think is hard to keep in mind, which is the market price or market value of a kidney in a world where it's illegal and versus where it's legal and encouraged is going to be different because the number of donors is going to change and the number of recipients is going to change because they're going to feel more comfortable using such a system, right? To me, the idea of flying to a poor country it's very unappealing, but I guess if my life were at stake or in dialysis, I might think about spending all that money. But certainly on the donor side, a lot more people are going to donate kidneys if they feel it's safer, if they are going to be paid. And so the market price, whatever that price is going to be in a rich or a poor country, and if it's a global market, there might be something closer to a world price. It's hard to know really what that would be. So in the United States where, a kidney operation is a kidney transplant, the operation part's very expensive. There's no cost out of pocket for anybody for the kidney. It's donated out of pure altruism or either alive or dead. No one's getting compensated directly in cash. If we allow people to be compensated in cash, the amount that would be is very hard to know what that would end up being in a market.
Well, some economists have tried to put a figure on that.
They would. Yeah. They would. Yeah, go ahead.
$15,000 was one that, let me see who this was, have come up with as a figure that takes into account the pain and suffering, the risks, et cetera. Gary Becker from the University of Chicago, who no doubt you know well. And
he was my PhD advisor, as it turns out. Yeah.
Is that right?
Yeah.
Okay. And Julio Elias, from an Argentine economist, did a study and came up with a $15,000 figure. Now, if you translate that into Iran and you divide it by cost of living, that's about what Iran is paying. Mm-hmm. Or Iran, what Iran is asking patients to pay anyway. Yeah. Yeah.
Interesting. So there's no way of knowing. It's interesting. It's a good starting place. But let's get to the moral issues. Why do people object to the morality of it? What is the moral objection?
Several reasons. I mean, first of all, there's the idea that this is your body, and we're going to pay you to sell me a part of your body. That's a big one. And the answer to that, in a sense, is, well, we do that in some ways. I mean, people get paid for donating plasma in the United States, and in fact, we are because of that, we provide plasma to the world. We get paid for donating sperm. We get paid for donating eggs. So that train has left the station in a way. And in some ways, the ethical and moral issues about egg donation are far more fraught than they should be about a kidney, because you're not producing another human being.
Yeah.
Then there's the issue of, this is really dangerous work, and exploiting the poor by taking advantage of their poverty to lure them into doing this for money. And there are some people who go so far as to say we shouldn't allow poor people to donate kidneys. We should only allow middle-class people to donate kidneys. And the response, I think, to that is that, people do dangerous things for money all the time. There's a lot of jobs that are pretty dangerous, and people wouldn't take them unless they felt the money was worth it. Donating a kidney is far less dangerous than many other jobs. So what's wrong with that?
Just as an aside, it's always hard to remember this. When the draft in the United States was replaced with the volunteer army, a similar argument was made.
Exactly.
We're only going to get poor people, forgetting the fact that, well, there are some poor people. That's fine.
Isn't that true?
Yeah. Well, it's not totally true, though. There are a lot of people who go into the army today, quote, not for the money. They're happy. They're perfectly happy to be paid. But there's a mix of motives, just as I assume people would donate kidneys for a mix of motives. Poor or rich, there would be the money. That's pleasant. But they also would like the honor and glory and wondrousness of saving a person's life. I think that would be, and I think that's just as true for everybody in the world of commerce. I think it's a shame that we assume that everybody in the world of commerce is, quote, motivated by money. Money has incentive effects. It can alter behavior. It can encourage people to do something they might not otherwise do. But to suggest that's, quote, the reason is, I think, very misleading.
Yes.
Why did you?
I think the army, the military issue is in some ways a bigger problem, because you have the issue of, if only poor people serve in the military, you don't have the political pressure from their families that you might have, that were, for example, very important in ending the Vietnam War. I mean, taking away the college deferment during the draft in Vietnam was extremely important.
Yeah,
because it created a class of powerful people who had their kids serving. But that's not an issue with kidney donation.
Yeah, the flip side of that, people make that argument. I think it's true. The flip side of that, of course, is that if you have to pay people to get them to risk their lives, if you go run around risking people's lives through adventurous foreign policy that's ineffective, you have to pay them a lot more to come into the army, no matter how, with their motivation or poverty. And so that market signal also plays a role in deterring adventurism, I would call it, or there's probably uglier names, but you get what I mean. But anyway, going back to the kidneys, so as you point out, these moral issues to a large extent, at least for you, are not decisive any longer. But for many people, they are. It's just awful. To encourage people to cut themselves open for money is disgusting. It's bad. It's bad, especially for poor people. Your body is a special, holy, sacred thing, and therefore it's just off the table. And I think that's true, by the way, for people, whether they're religious or not. A lot of people feel that way. Now that you've feel differently, do you find yourself in conversations with doctors and medical folks, some of which we'll talk about from your article, but they haven't seen the world the way you see it? And how is that, what's it like for you to deal with that?
Well, I just want to add one more piece of this, which is that, yes, if your body is a sacred temple, then let's spare some thought to the thousands of people who die waiting for a kidney.
Yeah.
I mean, yes, it might be. Let's stipulate that, okay, it's morally repugnant to pay somebody for donating a kidney. It is certainly more morally repugnant to let someone die because they don't have one.
I couldn't agree with you more, but we're in the minority right now, I think, in the United States.
It's changing, actually, okay. And there's some studies that show that it's not actually that much of a minority position.
Well, I guess that leads me to my less than attractive thought, which is, I suspect some of the people who are putting up a stop sign for this kind of innovation in the United States either have might have some not so attractive reasons for holding their views. Did that cross your mind?
What do you mean?
Well, let's say I'm in the kidney transplant business, and of course, one of the ironies of all this, I think you talk about it. It's a pretty obvious thought, is that the donor's not allowed to make any money, but the doctor is. The doctor isn't expected to volunteer.
The donor's the only person who doesn't profit in the system.
The hospital makes money.
But I don't see why that would lead people to oppose why that would lead people to oppose paid donors.
Well, because here's my thought. I think there's two issues here. One is, by one number I saw, it might not be up to date, but it's within the last 5 years. This is roughly a $42 billion. Kidney dialysis is a $42 billion market.
Yeah.
So I could understand how it might be easy for people involved in that market. And there are a lot of people, not just the people who make dialysis machines, but experts in that market. They kind of have a natural bias toward the status quo and are going to find these moral arguments more compelling.
You raise a good point. Although, frankly, there's so many people who need kidneys, and that list is going to be growing, that I don't think there's going to be any shortage of people who need dialysis. But I think I have not yet talked to anyone who opposes this idea on what I feel are immoral grounds. People have genuine concerns. I might not agree with them, but they're genuine, and they're genuinely held. And one big one is the U.S. sometimes sets an example for other countries. And we might be able to design a system that adopts the good parts of the Iranian model and fixes the bad ones. But then other countries, we will have essentially liberated the idea of it's okay to pay kidney donors. And then you'll have lots of countries doing it who won't be able to assure that it's done and without exploitation.
Well,
so that's one concern.
I wouldn't question anyone's motives, but I wouldn't put aside the possibility that their own self-interest colors their views, even though
kidney
they may
doctors don't have that interest of the dialysis company.
I'm afraid. I think they do, actually. So let me get. That was my next point. So,
all right.
Sorry. Yeah, it seems like a legitimate point, but I'm not sure it's true. So here's the counterpart. If you ask, and this just, I always find this fascinating, if you ask a college football coach what he thinks about the idea of paying players, which is an idea that has come up in the last 5 to 10 years as a somewhat serious proposal. It's drifted from an economist blogging about it to serious. And the NCAA has vigorously opposed this. And occasionally I'll hear a football or basketball coach interviewed where they'll say, oh, it's a ridiculous idea. And they'll laugh it off as if it's absurd. And, of course, they mean it. I think I heard Roy Williams react that way. Roy Williams, the coach at University of North Carolina. I was an undergraduate there. I like the basketball team. They've got a few embarrassing scandals right now. But on the surface, Roy Williams appears to be a really fine, wonderful human being. And he may not be. I have no idea. But he comes across that way, which, of course, is part of his job. But when he reacts that way, my first thought is, well, he would. Because right now, college sports is exceedingly profitable. And it's an extremely competitive business. And normally that competition would encourage the payment of large sums of money to the best college athletes and some nice sums of money to the very good ones. And some of them wouldn't get paid at all. They do it for fun. And that would be for the hopes that they'd get looked at and maybe have a chance to make the pros. But that would probably mean smaller sums of money for the coach, because that's where the competitive pressure now is released. The schools that compete, instead of competing by paying the athletes, the best athletes, the highest amounts, they compete by paying the best coaches. And so I wonder if in the kidney market, the salaries going to doctors would be the same in a world where donors are paid.
Where there were more kidney transplants?
Well,
you think their salaries would go down if there were more kidney transplants?
That's a good point. But I'm thinking of the fact that the amount, I'd say it's an ambiguous question. I'd say the that part would tend to have them paid more because there'd be a higher demand for their services. There'd be more operations done, but the amount they might get per operation might go down dramatically. Now, of course, we don't have a free market in surgical procedures, but there'd be budgetary pressure. It's all what I'm of a different kind.
I disagree. We're going to agree to disagree on
That's
this
fine.
one. I do not think that is what's motivating people.
Well, I don't think, again, if you asked them, they'd say no. And I would just say let me say it in a more polite way. I don't think they're sitting around rubbing their hands together saying, I'm making a lot of money. This is fantastic. And I don't care that there's X thousand people dying a year from kidney failure. No. But the status quo is very good to them. That's maybe a more attractive way to say it. And so, change is intimidating.
Doctors do not like watching their patients die because they cannot get kidneys. That is not something doctors like. And
so why aren't they on the forefront of this movement? Why aren't they on the barricades like you and I are?
Let's get to that.
Okay,
Let's get to that.
Go ahead.
There is a very strong movement now in the United States. In fact, I would be very surprised if it doesn't prevail, and very soon, that at least, if not compensating donors, removes the financial barriers to donating a kidney. Now, the problem is in the U.S., you can either get a kidney from someone who has died, or you can get a kidney from a friend or relative. But that friend or relative has to go through a lot to give you a kidney. They have to take a month off from work to get better. They may have to travel because they live in San Francisco and you live in Charlottesville. And, they have to come for testing and they have to come for the operation. It's financially a very large burden for them. There are cases where people who are perfect matches don't donate because they can't afford, they don't have anybody to take care of their kid for a month and they don't know if their job is going to be waiting for them. Sure. This is not an activity for poor people. And that's a very large problem in the United States. Our system is discriminatory because poor people do not have the same access to live related donors that wealthier people do. So there is a movement now to remove those disincentives, to allow compensation for lost time at work, to provide people, in some cases, with health insurance. Some people have proposed giving them health insurance for life because who knows, you might have a complication 20 years from now from donating your kidney. And the line between compensating donors and removing disincentives is a very fuzzy one. But there is definitely almost unanimous political will for removing disincentives.
Yeah, and again, to keep up the sports analogy, college athletes, some people will say, well, they do get paid. They get free tuition, they get room and board, and that's true. But it's not, I suspect, the market price. It's interesting how people will accept that, but that to go a little bit farther across that line into and here's a little extra or a lot extra. Mm-hmm. So, to come back to your earlier disagreement, a minute ago, I think for some people it's just a philosophical disagreement that economists are much happier being on one side of than, say, non-economists. So, your comment that some people are worried this might become a role model for other countries who might not do it as well. And my thought is that would be glorious. That would be great. I'd love to see other countries do it, even not as well, because it might be better conceivably than what they currently have. And if you...
That's a good point.
But it doesn't... I think for a lot of people that doesn't carry much weight because they just don't like the intrusion of a decentralized, possibly profit-driven market system. And I get that. I don't agree with it, but I get that. I think that is another piece of this that I think ties into the commodification issue. You're selling part of your body. People are uneasy with market forces encouraging things that they don't like or that they're not.
I'm thinking of what somebody told me. I was talking to somebody about a proposal that would compensate the families of people who have died for donating their relative's kidney. And the man I was talking to said, oh, you don't want that, because then you'd have the specter of the family just fighting over who's going to get the money. And I was thinking, yeah, this is the first time that a family will have fought over who gets the money from a deceased person.
Right. That's not a good argument.
We have a time-honored tradition of that in the United States.
I think all over the world.
Expand it a little bit more. Yeah.
But there is an issue we haven't talked about, which is the so-called slippery slope issue. Yeah. I think the more worrisome thing is let's not let's not take care of the relative, because when the relative passes away, we get this big windfall from the kidney donation. I think that, or the general, there's a hideous scene in Monty Python movie of, we only take the, it's a live transplant. The doctors are removing the kidney from a patient, and he says, but I'm not dead. He said, oh, you will be when we're done. And of course, that's a really dark humor. But the joke there, not the joke, the serious issue is, will people be less, if we commodify again some of these things, or we allow people to be relatives to be compensated, will there be less careful about preserving life, et cetera?
And anyone who stands possibly to inherit money from somebody has those same financial pressure on them, which we hope that they will overcome.
Yep.
But it's not something, what we're talking about isn't something new to add that extra financial pressure.
Yeah, for sure.
And the other problem is that very, very few people who die are medically qualified to donate your kidneys. You have to die in a certain way. You have to be brain dead. And yet the rest of your organs are still working. So that is a situation where relatives are asked to make decisions. And so what you're talking about may come into play. I think it can be an issue in that case.
The other issue, I guess, is budgetary at the governmental level. As our population ages, we're going to face an issue, and as we get larger, we're not just getting more numerous. The elderly, we're going to get larger because we're going to, as you say, we're going to be more obese. We're going to be more likely to have diabetes. We're more likely to have kidney problems. The budgetary pressure on that dialysis payment is, I suspect, going to be a part of what pushes the political system towards allowing some of these innovations. Do you agree?
Yes, and it's a terrible pressure. I mean, I was just reporting a story in Mexico, which is somewhat related, and they don't cover, their health system doesn't cover dialysis. So you either pay for it yourself or you die. The reason they don't cover dialysis is if they covered dialysis, they would not be able to do anything else. Yeah. Anything. So there is that. However, just as an example of how irrational Medicare can be, Medicare will only pay for 3 years of anti-rejection medicine for people who have a new kidney, which is absurd because that means they're likely to lose their kidney and therefore need another one or go on dialysis. That is such an incredible false economy, but yet that's the way it works. And people throw up their hands and say, this is ridiculous, but it's still the system. So
it's
logic
very expensive.
Doesn't always reign.
I think it's $14,000 a year for that medicine. So that's part of it. But it does make sense because the dialysis and everything else is even more expensive. So
exactly.
Yeah. We're almost out of time. First I want to salute you for changing your mind, which is something that we talk about here on EconTalk, how hard it is for people to change their mind, and in particular about a moral issue, which I think is particularly difficult for people. I'd like us to close by hearing from you how you feel in talking to people in the medical establishment. You feel like we're moving in maybe a more positive direction toward allowing some of these innovations. I'm curious if you're optimistic about it and if you think you as a reporter are going to play a role in that. You wrote a couple stories. They're very nice. They're up on the web forever, or at least for a long, long time. They might encourage somebody to think twice about it. Has this become a cause for you, or is it just something you've just changed your mind on?
It's not a cause for me. I mean, I think to me it seems like there's a clear direction in which I would like to see the country going, but I've written a story about it, and I'm not an activist on the subject. I do feel optimistic that there is going to be a movement very soon to make it financially, at least hold it financially neutral to donate a kidney. The problem is that is not enough. Yeah. That is not going to come anywhere near covering the need for kidneys. So I would like to see a serious discussion on the pros and cons, and I'd like to see some pilot programs try different schemes of compensating kidney donors on a small scale and see what happens.
Just on a factual note, I don't think I mentioned this before. I think there are about 87,000 people who die a year from kidney failure. Of course, they're not all candidates for transplants, but tens of thousands are. And to come back full circle on our sharing economy, I think we're moving toward a world of driverless cars, which I think will be a great thing. And one of the effects of that will be, thank God, fewer people dying in car accidents. But that will mean fewer deceased kidney donations, I think, unless I have that wrong.
No, you're right. And that's motorcycle helmet laws have actually greatly decreased the number of available donor kidneys.
So as a result, the gap between the people who could use a kidney, it's tens of thousands of people who die each year who, if this changed, maybe would still be alive. So it seems to me it's something worth taking pretty seriously.
I agree.
My guest today has been Tina Rosenberg. Tina, thanks for being part of EconTalk.
Thank you for having me.
This is EconTalk, part of the Library of Economics and Liberty. For more EconTalk, go to econtalk.org, where you can also comment on today's podcast and find links and readings related to today's conversation. The sound engineer for EconTalk is Rich Goyette. I'm your host, Russ Roberts. Thanks for listening. Talk to you on Monday.